Hello there. I am Dr. Krishna Prasad. I am the senior cardiothoracic surgeon at Medicover Hospitals, Madhapur. Today, I want to discuss about coronary artery bypass grafting. Now, what does this mean? In common language, many people also use the term CABG. That's just an abbreviation of coronary artery bypass grafting. Basically, it is an operation that is done for a condition called coronary artery disease, in which there are blocks that will develop in the arteries supplying the heart. Now, for this, we need to know what is coronary artery disease. Now, for various reasons, including aging, the blood vessels supplying to the heart, which are majorly 3 in number, and they can have major branches as well. These blood vessels, which are supposed to be soft and supple, they start becoming hardened. Not only hardening, fat, minerals and calcium starts getting deposited in certain parts of these blood vessels. And when that the block or the deposit becomes significant enough and it starts protruding into the tube, then it will start blocking the blood flow through this tube. And that's why they are called blocks. And the presence of these blocks in the arteries supplying to the heart is called coronary artery disease. Basically, coronary arteries are the arteries, name of the arteries supplying heart. So, who gets this coronary artery disease and why are we so worried about it? Coronary artery disease can be lethal, it can kill people, and to be honest, that is one of the leading causes of death in the world as we speak. Coronary artery disease is a result of certain risk factors that we have identified. First and foremost is genetic predisposition. So, if your parents had it, there is a good chance that you may have it. More importantly, there are correctable causes which can prevent this or delay the onset of the disease. Most importantly, diabetes, high blood pressure, having high cholesterol levels in the blood, eating fatty foods, not doing enough exercise, and these days stress, and of course smoking and other bad habits like alcohol. All of these can contribute to the development of these blocks in the arteries supplying your heart. Now, why should we worry about it? When these blocks become more than 70% in the artery, that's when they can cause symptoms. The most common symptom is called angina. Angina is nothing but a feeling of chest tightness or heaviness on the chest whenever someone does an exertion, like going uphill, walking uphill, or when they are going up the stairs, or when they are doing some kind of an exercise, or when they are excited and the heart rate goes up. In those situations, if they are experiencing chest tightness or heaviness, that symptom is called angina. When the block becomes more significant, the angina can be precipitated or brought on with less and less amount of exercise, and sometimes even at rest people can have this chest pain. When the block becomes 100%, and that too in a sudden way, when a blood clot comes and blocks this narrowed part of the artery, that's when people end up in heart attack. Now, depending on the size of the blood vessel that is blocked and the amount of heart that it is supplying, the heart attack could be involving a larger area of heart, which can lead to death of that person. And that is the reason why we are so worried about it. Now, when to act. If you have any symptoms or anything related to those symptoms that I had mentioned, sometimes the angina is present like a neck pain or jaw pain, which is radiating to the left arm. It could be a dragging sensation in the left arm, or it could be pain in the back. Any of these symptoms, or even if you don't have these symptoms and have the risk factors, like if you are a diabetic, hypertensive, and your cholesterol levels are high, you are in your 40s, your parents had this kind of problem, then it is worth getting a thorough cardiology check like echo, treadmill test, ECG, and then seeing a cardiologist on a regular interviews to make sure that you are not falling into this risk group, or already some of these blocks have started developing. Now, what could we do if these blocks have already developed? What are the treatment options that we have got? Now, there are two kinds of ways we can treat this problem. One is what the cardiologists do is first to identify this problem, we need to do a coronary angiogram. A coronary angiogram is done basically by putting a small tube through your hand or sometimes through the leg artery. The wire is passed close to the heart and an injection of a dye containing iodine is given to see where the blocks are. So that is the roadmap based on which we plan our treatment. If there are only one or two blocks, the first modality of treatment or first option of treatment will be what we call as stenting, or sometimes called as PTCA, percutaneous coronary catheter intervention. So this particular procedure is done by cardiologists. What do the cardiologists do? They, similar to the angiogram, they pass a balloon and go to the point of the narrowed part of the artery, inflate the balloon, open up the blood vessel, and to keep it open, they leave a spring-like device called stent. So that's the reason why this is also called as stenting. Now this can be done if the blocks are 1 block or 2 blocks, maximum 3 blocks. In some instances, more blocks can also be dealt with. But in some situations, the blocks are at branching points or at difficult points where the stenting is not possible, or sometimes if it is involving the main blood vessel supplying about 90% of the heart on the left side. In those instances, we take the second option, which is the bypass grafting. In bypass grafting, what we as surgeons do is that we take a blood vessel vein from your leg, an artery from behind the breastbone, sometimes an artery from the forearm, and use these to construct joints before and after the block. So to give an example, it is like the bypass roads that are bypass the traffic past villages. So we create an alternate route for the blood to reach to the heart, so that the blood flows through this and the block, irrespective of whether it is 100% or 90%, doesn't matter, and enough blood reaches the heart so that a future heart attack can be prevented and the symptoms like angina can be prevented. So these are the two modalities of treatment. Now what are the advantages and disadvantages of both? PTCA is a procedure that can be done just like an angiogram, so you need to stay only for a day or two in the hospital, and then you could be discharged. And you could get back to work soon as well, maybe in a week's time, maximum in a month's time you can be back to your normal activities. Whereas with bypass, the recovery time is slightly longer. You have to stay in the hospital for a week, and the recovery time will be maybe a month and a half if you are doing a desk job, that is writing, computer work or something like that. And if it is heavy work involving lifting heavy weights, you may have to wait till 2 to 3 months before you can join back to your work. There are certain advantages and disadvantages with both the procedures. The stenting can get blocked within the first 6 months, but if enough precautions are taken and the stents don't get blocked in the first 6 months, then they could last longer. Whereas the bypass, the risk is with the only initial period during the surgery. The long-term results with bypass are much better. Now, let us talk more about bypass operation. How is it done? What are the options that we have got in bypass? What are the different kinds and why we should be having discussion about these things? I'll try to elaborate as much as possible, but because this is a video, there is a limitation in how much information that can be given. So if you have any further doubts, please do contact your heart surgeon and they will give you more information about this. As I mentioned earlier, bypass operation needs to be done either by using the leg veins or through the using an artery from behind the breastbone. Now, how do we approach the heart? Nature has protected the heart in a very nice cage, the bony cage, and it is surrounded by lungs which act as shock absorbers. So it is nicely protected and tucked away so that it cannot be damaged. And that creates the problem for the surgeon as well as to how to reach to the heart so that we can do the surgery. And here the common and the traditional way of doing surgery is what we call is, we cut through this breastbone and make a cut in the middle of the chest and cut through the breastbone. At that time, the heart is nicely in front of you and you can do all heart operations through this approach. But obviously, the concern is this, there will be a big scar and we need to cut through the bone and that will delay the recovery process. And here, we need to have clarification about some terms. Many people refer to the term called open heart surgery. Now, for a common man, what it means is different from what the doctors mean by open heart surgery. Open heart surgery for a common man means that you are going to open the chest and then have a look at the heart directly and do the operation. Whereas for a surgeon, the open heart surgery means if we are opening the heart and going into the chambers of the heart, which is not necessary for a bypass operation. So there is a slight variation in the understanding of what the terminology is, but for common people it means opening the chest. In recent days, with advanced technology and more understanding of how we can do this operation, the same bypass operation can be done through a keyhole. Rather than opening this chest, we can do a small cut in the left side bottom part of the chest, and with that we can access the heart, do the bypass grafts, and then patient will only have this small cut under the breast here, and so no one will ever know that the patient had a bypass operation, and also the recovery time will be much faster, the pain related to the operation will be much less. But minimal access surgery is not for, or keyhole surgery as it is called, is not for every situation and not for everyone. It involves specialist training and a lot of complexity is added to the procedure. In front of the chest, it is very easy to approach the heart, whereas through keyhole surgery, the access becomes difficult. If I can give you an example, it is like repairing a watch which is right in front of you, or if I put the watch inside a box, make a small hole and ask you to repair it through the hole. So that's the difference. You can still repair it, but it will take a little bit longer and the complexity increases. But with a competent surgeon who is trained in keyhole surgery, it is very much possible to do this surgery, and there are certain advantages with doing this. However, in some situations, keyhole surgery may not be possible. Here, a word of caution is important. See, the keyhole surgery, the advantages are that you will have a small scar and early recovery. But the most important aspect of the entire operation is the kind of joint we do on the heart. If that joint quality is compromised, then it doesn't matter from where you do, and if the joint gets blocked immediately after surgery, then all this effort is a waste. So we need to give the freedom to the surgeon to decide which is the best treatment for you and which is the best option for you. And the only difference, again as I said, between cutting the breastbone and doing it through a keyhole is the recovery time. 1 month will be gone in no time, but if the surgery is done well, that will last you for 15-20 years, which is more important. So we need to look at long term, and I request all of you to leave the decision to do whether keyhole or open surgery to your surgeon, because his comfort is of the utmost importance. The next topic is something called as beating heart surgery. Now, why do we need to do an operation on beating heart, and why this term has come? Traditionally, we all know that the heart is a pump that keeps beating all the time, and the arteries that we are supposed to operate, the coronary arteries, are about 2 to 2.5 millimeters in size. So they are actually small in size. And to do a good joint on such a small blood vessel with the heart beating away is difficult. So traditionally, the way heart surgery has developed till up to 2005 is that we divert the blood from the heart into a machine called as a heart-lung machine, which does the job of heart and lungs. And whilst the patient is being managed with the heart-lung machine, we stop the heart temporarily and do these joints. And once the joints are made, we put the blood back into the heart, get it pumping, and then get it going. So this is what is called as on-pump surgery. That is because we are using a heart-lung machine which is called as a pump. So this is called as a on-pump surgery. Now, with recent advances and more understanding of how we can do the surgery, we have developed a technique called as a beating heart surgery. In beating heart, what we do is we have a special device called an octopus. The octopus has got a flexible arm which has got 2 feet, and what it does is it stabilizes only that part of the heart which needs to be stabilized, and rest of the heart is beating underneath as it is, and only the part where we need to operate is stabilized with the octopus. And with this, we will be able to do the bypasses. Now, the advantage of this procedure is that we need not divert the blood from the heart into a machine, and all the exposure of blood to the machine and all are reduced. So, over a period of time, people have got used to this technique, and there are certain advantages with that. Although the advantages are not huge, in the sense that despite studying thousands of patients, when compared to doing the operation on pump versus beating heart, scientists and research could not demonstrate a significant difference in between both groups. So, what it means is, it really doesn't matter whether you do the operation on pump, or we stop the heart and do it, or you do beating heart. But proponents of beating heart and surgeons who do beating heart surgery regularly, they claim that their results are much better with beating heart, which makes logically sense, but it has never been proved. Again, we come to the point of how well the joint is made on the blood vessel is most important, rather than how we are doing it. And this choice, again, you should leave it to your surgeon, because surgeon's comfort is the most important thing. In some situations, even a surgeon who is usually used to doing a beating heart surgery may prefer to do it on pump. That could be because the heart pumping is weak, or sometimes during the operation the heart is not tolerating positioning it and then stabilizing a little bit of it. So, for all these reasons, I think the decision should be made with the surgeon, that whichever way he prefers to do the surgery, because at the end of the day, what really matters is how well the joints are made on the artery, because that will determine how much the blood flow to the artery is improved, and also the long term results, how long the bypass graft is going to work. So, you could ask the options and how the surgeon wants to do the surgery, whether beating heart or on pump. But I think ultimately, sometimes it's the choice of surgeon, and sometimes the situation may demand that the surgery could be done on pump. So, those are the important points you need to know about beating heart surgery and on pump surgery. The next important point that we need to talk about is what kind of blood vessel we can use and how it's going to influence the long term results. As I mentioned earlier, we can use the vein from the leg or an artery from behind the breastbone, or sometimes we can use the artery from the forearm. Now, recent days we use both the arteries on both sides of the breastbone. The artery on the left side of the breastbone is called left internal mammary artery, or in many operation notes you would find it as a short term as called as LIMA. And if it is on the right side, it is the right internal mammary artery, or RIMA. Whereas the artery from the forearm is called radial artery, and the vein from the leg is called saphenous vein. Now, why is there so much of variation, and why is there so much of a choice? You can understand that the vein from the leg is like a spare part. There are two main veins that bring back the blood from the leg to the heart, and the one that is most superficial, just under the skin, is the one we commonly use. Obviously, the legs are long, so we have got plenty of length of the vein on both sides that can be used for an operation. So, if someone needs more bypasses to be done, when I say more bypasses, there are three main blood vessels supplying the heart, but they could have bigger branches which have blocks, and they may need individual bypasses to those branches. And in those situations, we may end up doing 3, 4, 5, sometimes 6 bypass grafts as well. So, when we need a longer length of blood vessel, then we end up using the vein in the legs. The advantage is you have got plenty of length, very little possibility of complications because the cut is just under the skin, and of course, it will be adding one more cut to the leg, but that has been how surgery has been done traditionally till up to the 2000s. Recent studies have shown that clearly, because the vein does not belong to the arterial system, and if you are putting it on it, there is a chance that these veins can get blocked within 7 to 10 years, or sometimes less than that. That is because if the patients don't take proper care of themselves and control the risk factors post-operatively, the veins tend to block earlier. So, scientists came up with this idea that why don't we use similar arteries, and hence for the size match we use the artery from the forearm or arteries from both sides of the breastbone, make a Y joint with them, and then make jump grafts with these, using these arteries. And these blood vessels have shown that they have better long-term results. When I say long-term, after the operation, if the graft is working for 15-20 years, we call it as a good long-term result. So, if someone has an operation around the age of 60, and if the bypass grafts are working for them till 80 years of age, that's pretty decent result. But again, we will talk about the advantages and disadvantages, how to look after your grafts later on in this video. But most important thing to know is, some situations the arterial grafts may not be possible to be done for all the patients. It predominantly depends on the anatomy of the heart and your heart blood vessels. Depending on that, the surgeon can decide whether arteries need to be used or veins need to be used. And in most instances, people in whom whose age is more than 60 years, it doesn't make a huge difference between using a vein from the artery. So, if it is easier and it is better to use the vein, sometimes we end up using for elderly patients veins for bypass grafts. And in younger patients, the tendency is to use arterial grafts. But again, this choice and decision should be left to your surgeon. You can discuss the option, but the choice should be left to the surgeon. Ultimately, he is the person who is doing the joint, and he should be comfortable doing whatever procedure, because the final result and the long-term result will entirely depend on how well the joint is made in the first place. Now, how, people have all kinds of misconceptions about heart operation. How long does it take? How long does one have to be in the ICU? How long one has to stay in the hospital? In the 70s and 80s, the patients used to end up staying almost for a month. Patients used to stay up to 21 days after operation. Whereas now, with advanced technology and better understanding, we can discharge the patient in 5 to 7 days after the operation. The operation itself takes up to 3 to 4 hours duration from starting till end. And at the end of the operation, the patient is brought to the intensive care unit under anesthesia on a ventilator. Now, this is done to make sure that the heart is tolerating the operation well and the bypass grafts are working well. And because this involves a lot of joints and there is a risk of bleeding, so we need to make sure that there is no bleeding before we can wake up the patient. So, for the first 4 to 6 hours, the patient is kept on a ventilator and under observation in an ICU. And if once the bleeding is not there and blood pressure, everything is stable and the heart pumping, everything has stabilized and we know that the operation is working well, at that time we tend to wake up the patient, bring them out of the ventilator. This can be done the same evening of the surgery, or sometimes patient is kept under anesthesia overnight and the following morning they are woken up from anesthesia. Once they are woken up from anesthesia, and usually after heart operation, they are attached to some medicines used to maintain the blood pressure. And these medicines should be slowly, what we call as weaned off, or slowly they are tapered off or they are reduced in amount so that the patient is no longer on them. And this process usually takes 2 to 3 days after surgery. And for these 2 to 3 days, patient stays in the ICU. And at the end of that, they come back to the room. Once they come back to the room, they are pretty much independent. They should be able to walk to the bathroom, go to the toilet, and be able to walk small distances and so on. So, they are observed in this manner for another 2 to 3 days in the ward. So, following a heart operation, about 5 to 7 days later, patient should be able to go home. At the time of going home, at the time of discharge, they will be able to do pretty much what they would like to do, in the sense of, as I mentioned earlier, be able to go to the washroom, be able to have a bath by themselves, walk up and down the stairs. And in fact, we encourage them to walk at least half a kilometer to kilometer morning and evening after surgery, so that way they can keep themselves active. And they will also help with the operation, and if they are diabetics, that helps in the management of their diabetes as well. So, all in all, after heart operation, it is not like you will be bedbound for a long time, or you need to take complete bed rest for a very long period. you will not be able to return back to your work. These are all misconceptions. Usually, once you go home, you will be pretty much independent. And we recommend you sit in a chair or in sofa for the best part of the day. Be active for as much as possible, and maybe in a week or two, you can even resume your desk work, working on a computer, or reading from a computer, reading from a tab, and watching television, and all those things can be done from the day you go home. It all depends on how well you are coping with the surgery. Sometimes you might feel tired, some days you will feel low, but apart from that, it does not mean that you will be completely bedbound for a very long time. The whole idea of doing a bypass operation is to get you back to your normal life, make you normal, and get you even fitter than what you were before surgery. So, it defeats the purpose if someone is completely bedbound, and that is not the idea of doing heart operation. The topic that everyone wants to avoid is the risk associated with the heart operation. Obviously, heart is seen as the seat of life. If it is beating all the time, we feel that stopping the heart or doing a procedure on the heart can lead to complications. So, people are always worried about getting a heart operation done. Certainly, heart operation is one of the major operations, and that is associated with a risk procedure. But believe me, whenever we are offering a heart operation, we have done the thinking and analyzed the risks and benefit of a procedure, and then only a procedure has been offered to you. What I mean by this is that if by doing this operation the benefits are more and the risk is less, then only a bypass operation will be offered to the patient. If it is other way around, if the risks are much higher, then your surgeon will certainly mention that to you and tell you that the risks are higher, but the reasons why a surgery is being offered also will be told to you. Now, as our understanding of heart and heart operations has increased, there is a system of what we call as a risk stratification that has been developed, and one of the best things is what is called as a Euro score. You can check that on the internet. If you just say Euro score, EUROSCORE, Euro score 2, then it opens a link and you can go to the website and calculate your own Euro score. Now, the score involves certain parameters or certain risks that the patient has, their condition, and the surgeon has to enter those conditions into the calculator, and then it will automatically give what is the risk of this patient dying because of the operation, or what are the benefits they can have, what complications they can have. Usually for a bypass operation, for someone who is under 60 years or about 60 years, who have got a good heart pumping, the risk of bypass operation is less than 1%. What do I mean by that? That means if we operate 100 people, 1% might die because of the surgery, but 99% there is a success chance and 99 people will survive. When the risk is increased to 2 to 3%, if the heart pumping is poor, if they have previous lung problems, if they have kidney disease, if they have diabetes, if some other procedure is being done along with bypass operation, in those instances the risk goes up. So, the more number of procedures we add, or if the patient's condition is poor before operation, if they are on BP medicines before that, if they had a recent heart attack, and criteria like this, in those instances the risk of the operation goes up. But still the operation is being offered to you because this is the best way to save the patient's life, and if we don't do anything, the risk will be 100%. The way these blocks work is that without an intervention, without stenting or bypass, as of now, the blocks do not dissolve by themselves. Something needs to be done. If nothing is done, then what would happen is that the blocks will become 100% sometime, and that will cause a heart attack, and if it is a major heart attack, it could be life threatening. And hence, whenever we see those kind of blocks which are more than 70%, we advise patients to undergo one of the options, either stenting or bypass. And if it is bypass operation, then believe me, that is a better option. Even though the risk mentioned by your surgeon is there, but that risk is much less than not doing anything. And these diseases, these blocks will not go away with just medicines. So, If you have any concerns, please discuss with your surgeon and ask what is their actual risk. And if you need be, you can calculate your own risk, as I mentioned, with the Euroscore calculator, which is available online, and that would give you the risk of life-threatening complications following heart operation. Having said all these things, over a period of last 50 to 70 years since heart surgery has started, the risk of doing operations has come down dramatically. And this on top of operating on more complex and more sick patients. So it is commendable job that such a complex operation on such complex patients is being done for such a lesser risk. So again, I go back to the point that when the treatment is better than not treating, then only a bypass operation would be offered to you. And so it is always in your better interest that you take the option and be benefited by the surgery. Now, what are the long-term benefits? Why should we undergo such a complex and risky procedure, putting our life at risk? The advantage of bypass operation has been proven beyond doubt. Since 1970s, when the operation has started, people have been following up patients after their operation, how long these patients are doing well, how long the bypass grafts are working, and who are the people who are actually benefiting from this operation. And we have got robust data which suggests that bypass operation is much better for patients who have 3 or more blood vessels blocked, if their heart pumping is weak, or if their main blood vessel, which we call as a left main stem, that is LMS, if their left main stem is got significant block. In all these instances, a bypass operation tends to work better, both in the short term and in the long term. The risks that I mentioned earlier are usually for the first 24 to 48 hours. Once the patient comes out of this risk period, the chances of any fatal or any high risk complication happening is very less, and the patients continue to get better, and the operation works for them for 10, 15 to 20 years depending on how well they look after themselves. Here, one thing we need to understand, as I had mentioned earlier, the entire nature of the operation is that we are bypassing the blocks with some blood vessels, but we are not doing anything to the process that causes these blocks. And so it is important to understand what are the processes that are causing the blocks and stop those processes so that the blocks do not happen in the new blood vessels that we have put. So again, to mention those risk factors that causes the blocks are diabetes, high blood pressure, high cholesterol levels, oily foods, not doing enough exercise, stress, smoking, alcohol. All these things are the risk factors that cause these blocks. So following a bypass operation, if you don't control these risk factors, the blocks are certainly coming back in the new blood vessels and in the old blood vessels that were there. And again, you would come back with symptoms in a short time. So it is very important to control the risk factors. And if the risk factors are controlled well, then the operation will work for a very long time, up to 15 to 20 years. Now, some of the frequently asked questions of following a heart operation is, when can we join back to work? Are we going to be bed bound, or we need to take bed rest? The answer for these is that if the surgery has been done through a open heart surgery, or if we have opened the breastbone and put it together, the time taken for the breastbone to join together is about 2 months. So till 2 months, you are not allowed to lift weights or bend down or do any heavy work that will put strain on this. It has got nothing to do with the actual heart operation that is happening inside, because the heart operation is working from the moment we have done it in theatre. So that has got nothing to do with it. The only precautions are for the breastbone to heal and not to put pressure on it while it is healing. Whereas if it is a keyhole surgery, then that problem is reduced and the recovery period is much earlier. As I mentioned earlier, people who go back to home, they need not be bed bound. In fact, we encourage them to be active, and they need not take complete bed rest all the time. They can do small activities, going up and down in the home, watch TV, read books, write letters or books, whatever they want to do. And small things like making tea and can be also be done the moment they go home. So it is not an operation where you will be bedbound or you are incapacitated in some way, you cannot do things like that. Till 2 months, we advise patients not to do driving, either two-wheeler or car, because we never know when a situation comes where you are having to apply brake and that might apply pressure to the operating area. So for that reason, we ask you not to drive. Equally, up to 1 month after the operation, patients are not allowed to fly in an aircraft. But again, there are exceptions. Beyond 2 weeks, if the patients are from an international destination, they should be able to fly, and we could arrange for the precautions that need to be taken if someone has to take a flight within a short period. Apart from these, doing a desk job and things like that should be able to be done from 2 weeks after the operation or from point of discharge. Lifting weights, anything above 5 kilos, shopping bags or any weights, even children, we discourage that to be done before 2 months. Those things can be done after 2 months or 2.5 months after surgery. And equally, lifting any other kind of weights or doing heavy jobs like driving a lorry and all those things should be postponed beyond 2 to 3 months after surgery. Apart from these precautions, people can get back to their normal life as soon as possible. Some people ask the question that they come from a faraway place and whether they can go back to their place. Of course they can go back, because what we usually advise is after surgery, when the patient gets discharged, they are asked to come back within 7 to 10 days for a quick checkup to make sure everything is going well. They are following the instructions given to them, and they are taking their medication regularly and so on. So even for that, they can travel up to 500-700 kilometers to go home and then come back. That's not a problem at all. But when going on these long trips, it is very important to take frequent breaks. Whenever there is a break, just to walk a little bit so that you can prevent clots from forming in your legs. That is the only precaution that needs to be taken. And of course, precaution to make sure that the pressure doesn't fall on the operation area, and to travel safely and smoothly as far as possible. So in conclusion, what I would like to say is, bypass operation is a relatively safe operation despite all the fears that people have. And believe me, getting the operation done is much safer than not getting it done. The example I keep giving to patients is that, if you are driving a car, and if the nuts to your tire are loose, how long you will go before you stop and fix them? That is the same thing that is happening with bypass operation. The sooner you fix, the better. If you don't fix and continue to drive the car, at some point the wheel is going to come off and the car might crash. We don't want that to happen with you. Hence, when your surgeon is advising you to go for an operation, please go ahead and get the benefits of the heart operation. Thank you.